Okay, perfect. Well, yeah, well, firstly, yeah, great to see so many people attending this, and yeah, saw a couple of names I recognised actually. So it seems like a great international audience, and yeah, well, hope you're well wherever you are in the world. Thanks for tuning in, and yeah, thanks obviously for the organisers as well for putting together this event. Looking forward to the other presentations and learning about what people are doing across the technology space in this incredibly important area at the moment. So yeah, I'm here representing reach52, based in Singapore. We are a health tech social enterprise that very much focuses on access to healthcare in rural areas. So we're in about 5 countries at the moment. We started in the Philippines, grew into Cambodia, India, Indonesia, and most recently Kenya. And yeah, we're really about sort of building tech that allows more rural communities at least 1 hour away from a pharmacy, if not normally 3 or 4 hours, to access healthcare services. And by healthcare services, we mean comprehensive primary care. So yeah, all based on tech, really about bringing healthcare to that last mile, and yeah, 5 markets and counting. So yeah, just our name. Firstly, people often think it's 52 weeks of the year. So one slide up front is, yeah, we take our name from the fact that 52% of the world can't access healthcare. We're trying to reach the 52%. And yeah, it's all sort of based on the thesis. We always like to put this up front, that traditional health services, pharmacies, primary care clinics, hospitals, telehealth models, in a traditional sense, just won't reach half the planet. So these 52% of the world, they live in rural areas, traditional brick and mortar infrastructure won't serve them. Traditional digital health models, you need a phone or you want to order your medicines online, also won't serve them, due to the lack of internet, lack of digital literacy, and so on and so forth. So yeah, we're trying to solve that challenge or problem and build an app that sort of bridges these two things. I guess another sort of really important upfront slide just to explain what we're actually doing. So yeah, we're going to these more rural areas, and we train a network of agents in villages and the community health worker. So yeah, we go to rural areas, train 1 or 2 people. It's not a B2C app, but we train the health worker, independent person, to use our tech. They firstly collect data on healthcare needs. So yeah, this trained health worker or trained person goes to every house in their community and collects data on healthcare needs. And then basically we do run sort of targeted health campaigns, which are often, so that's screening, awareness campaigns. We've done everything from dengue, COVID-19, diabetes, hepatitis, HIV, run, by these agents in a more targeted way with the government, and often, integrating B2B partners as well. And then lastly, yeah, we also give access to products, so working with medicines and insurance providers, both public and private sector, for our agents in rural areas to deliver these products back to the communities. So yeah, everything's sort of enabled by tech, but it's really train the health worker, train the individual agent, collect data first, run more targeted health campaigns, always with the government, always with an MOU, but also with private sector often involved. And then yeah, also access or manage the ordering and distribution of commodities as well. So yeah, through the agents, we manage the logistics. So yeah, we're not just an app. It really is about sort of empowering this sort of field force in the communities to deliver better healthcare in the community that they're within. So then, yeah, hopping over to the tech, that was, hopefully a useful 4 minutes in terms of what we do and how we run it. So yeah, our product, we're about 5 years old for what it's worth. We've rebuilt this product twice. We're on the second rebuild. We had our version 1, and we're on version 2. That's a better way of wording it. It's an Android app that the agents are using. It's fully offline. We run on Android 4.4, so pretty old. We generally work in the mean stack, so it's a sort of Mongo backend, but we do some structured relational database for reporting as well. Obviously, made our data comply to HL7 and SNOMED and FHIR, well, FHIR now actually, So yeah, generally just an offline first Android application, syncs periodically, pretty standard tech, and yeah, obviously conforming to all, you know, logical data standards. What you see here is the home screen that an agent would see, very basic user interface, sort of on purpose from a usability point of view, and also, you know, low spec devices. We run on 1 GB RAM on the phone, so we've obviously always engineered to make it pretty easy for the phone to handle. Yeah, there's the dashboard of users, managing the residents in the village, supporting appointments or referrals to the health system, managing local health events, health information and education campaigns, running door-to-door campaigns, and then you can also order medicines and insurance and stuff, but that's done through the residents tab. So yeah, we always try to say, if you think about primary care or accessing a doctor in a pharmacy, it's these sorts of functions, but we just do it within the app and work with local city-based providers for the fulfillment. So yeah, first step, as mentioned, we equip our agents with tech. This isn't a direct-to-consumer or direct-to-client app at the moment. We train the agents. They firstly go and sign up all the residents in their village to understand their healthcare needs. They then can manage their residents. So how many residents have they onboarded? Who do they have to go and re-engage? Because if somebody says, you know, they're diabetic or at risk of diabetes or pregnant, we sort of automate and trigger various activities. So let's just say somebody's pregnant and the kid's not been vaccinated. The automated re-engagement, which you see on the screen now, would be to go and show a video or whatever about, you know, the importance of vaccinating children. So yeah, sign up the residents based on the data collected, manage and engage the residents, which we automate through the sort of back end of the platform. And then, yeah, when we're re-engaging the residents and also training the health workers, providing e-learning content to a range of videos, PDFs and so on. If you're offline, you get pictures. If you're online, you can watch the video or sync it and save it for later, storing it locally. So yeah, a range of content for e-learning and upskilling, both for the health worker as well as the residents. And then, yeah, obviously when connecting the users, we're also doing a range of targeted events. So organizing screening campaigns, signing up residents for relevant health services, often working with the public sector to run local vaccine campaigns or screening campaigns, whatever it might be. We do a lot of door-to-door screening as well. So running these targeted screening campaigns with the health workers, and also managing medicines delivery, which again can either come from public sector, making orders of the available public sector stocks, or from private sector, you know, paying out of pocket. And we often work with private sector to make those products more affordable as well. So yeah, that's the sort of app at the moment. We've got about 5 or 10 developers. Yeah, it's sort of basic, but it's in about 7 languages, 5 countries now. Different backends, you know, as in data hosted in the market, so it sort of splits the data in the backend. And yes, it's going pretty well. In general, about 5,000 agents using, or health workers using the app at the moment. And then, yeah, just going down. So yeah, in terms of where we're going, I guess we are really thinking about how we continually bring in private sector, or not private sector, comprehensive primary care, sorry, for rural areas, as previously mentioned. So yeah, we're continually empowering and upskilling the agents. We are looking at basically activity and distance-based compensation. So basically paying them more the more that they travel. Oh, sorry, I went too many forward. So if they travel more or if they do more activities, they earn more. So starting to think about, you know, our engagement campaigns as additional revenue for health workers or additional income for health workers. Oh, sorry, it's going the wrong way. We're doing a bit around symptom checkers now as well. So we've got a sort of offline first symptom checker to support the agents in terms of clinical decision support. We're doing recommended next steps. So if a patient comes to you with A, B, C, you know, in terms of data entered into the app, moving that forward. We're also sort of looking at e-wallet integration, bringing in payments that we're launching this month for out of pocket. We're looking a bit at health points. So the more you spend on healthcare, you get points. Points can be used for discounts to drive affordability and adherence. And we're also doing quite a lot with income assessments. So assessing people's income through alternative credit scoring. That means differential pricing. So as in different prices for medicines, poorer people pay lower amounts, specifically for vaccines. So yeah, quite an exciting roadmap coming through. Yeah, and really just continuing to build this product. Basically out of time, but yeah, at the moment we've got about 600,000 monthly patients that use our services. We've got about 5,500 agents, so health workers and people using the app, about 20 B2B partnerships that fund our services, and about 7,500 discounted medicines that we deliver as well in the 5 countries. And again, Philippines, Cambodia, Indonesia, India, and most recently Kenya. So yeah, that's just a bit about where we are in terms of our sort of user growth with the app. And I'll pause there as I'm 30 seconds over, but thank you for the time. And yeah, welcome any questions, or please connect with me offline if you're interested to learn more.